Good evening, everyone, and welcome to tonight's Women Leading Philanthropy voting meeting. I'm Rachel Melky, the founder and CEO of Hillberg & Burke and the honorary co-chair of Women Leading Philanthropy, along with a Women Leading Philanthropy member. I am so excited to be here in person at the beautiful Broadway Theater as we gather here today. We acknowledge we are on Treaty 6 territory and the homeland of the Métis. We pay our respect to the First Nation and Métis ancestors of this place and reaffirm our relationship with one another. Although we are not all physically together in one room, the goal of this evening remains the same. I know you will be inspired, as am I, by the three amazing women physicians who are presenting tonight in hopes of being awarded the $100,000 WLP grant tonight. As always, we try our best to bring you a seamless production. Should there be any technical barriers, we just ask that you please chat in the Zoom box with us and let us know, and we will try to resolve them as quickly as we can.
So I'm going to just jump in here and say that goes for the virtual people at home that don't have a QR code yet. Just make sure that you type that in the chat box.
As WLP donors tonight, you hold a unique responsibility. You get to make a very important decision, a $100,000 decision that will improve and save lives for women in Saskatchewan. As a donor and a WLP honorary chair, this is a privileged decision that I am honored to make. And I know you at home and all of you in person are as well.
Well, thanks, Rachel. So I'm Mary Kinlock. I'm Rachel's co-chair, and I am the division head for anatomic pathology for pathology and lab medicine at the Saskatchewan Health Authority in Saskatoon and at the University of Saskatchewan. And we are so excited to see our membership of Women Leading Philanthropy grow over the years, although I do recognize that we have some first-time donors here tonight, and I just want to say a sincere welcome to you. And welcome to our journey of transforming women's healthcare in Saskatoon. And while I'm looking forward to introducing the three finalists, first I want to take you through a little bit of the process of how we got here. So earlier on in the year, we opened up applications for the Women Leading Philanthropy grant, and then we brought together all of the applications with our granting review committee, which was made up of physicians and RUH Foundation board members and members of the volunteer board and the steering committee and business leaders. And then that rigorous process resulted in three top-tier finalists that you're going to hear from tonight. And really what's most exciting about these brilliant women is that they are pioneers within healthcare in Saskatoon in their own right, and you're going to hear it from their story. They have provided an elevation to the healthcare that we deliver in Saskatoon, and they didn't even stop there. They said, I have more, and they've put the energy in tonight to tell you about how their project is going to bring us up to top tier level.
When we empower women, we truly all benefit. Women, our families, and our entire community. Women Leading Philanthropy continues to inspire me because we see the tangible results of the work and dedication of the female physicians who have brought forward these incredible projects. Shortly, each of our three finalists will have the opportunity to pitch their innovative project and illustrate how an investment in their work will impact practice and transform healthcare for women. But first, we want to provide you with an overview of the evening for you.
So each of the WLP finalists will have 15 minutes to explain their project to you. This will encompass a video and a 5-minute chat, and then a question and answer session between myself and the applicant. If you want to make some notes, you'll see that there's space provided in your program, or feel free to use your new Women Leading Philanthropy journal.
So each of you as WLP voting members will have the opportunity to cast your vote electronically this year. If you are a WLP donor, you will have been provided a QR code inside of your program that you can scan with your phone's camera to cast your vote. We wanted to make sure that everyone feels really comfortable with how to cast their vote, so we're going to have a little practice vote. So you're going to take a quick minute to do a practice session. So you can take out your phone, scan your QR code now, and cast your vote for whether or not pineapple belongs on pizza. So, very important decision.
I feel like I have to make a disclosure in that that's what we used to eat as kids. Yeah, pepperoni and pineapple. It was a big favorite. Okay.
So once your vote has been entered, you will see a green check mark with the word sent indicating your vote has been counted.
Oh, so that seems like an important part. Okay, yeah.
If you are in the room and have any challenges, just raise your hand. If you're at home and having challenges, please comment in the Zoom chat box. Cue the Jeopardy music.
All right, Trisha, are we going to be able to see it, or is that important, or you just wanted to let us know? Okay, it is working. Okay.
So following the 3 presentations, we will provide instructions on how to place your vote for the project that resonates most with you to receive the $100,000 Women Leading Philanthropy grant. While all 3 of these grant projects are worthy of funding, only the project receiving the highest number of votes will receive the grant.
And we also look forward to tonight hearing from Dr. Laura Hopkins, our last year's recipient for the Women Leading Philanthropy grant. You'll be providing us an update on your project, which we're all excited to hear about. And so now I'd like to formally introduce you to this year's finalists. Please join me in welcoming to the stage Dr. Brittany Ellis, Dr. Janine Eckstein, and Dr. Jennifer Brown Broderick.
Thank you to each of you for being here this evening and for your passion and commitment to excellence and innovation in healthcare. As I stand here with these inspiring women, I can't help but reflect on how much of an impact on women's healthcare that WLP has had in just 4 short years. After this evening's grant is awarded, we as WLP donors have raised and invested $500,000 to advance women's leadership and healthcare in Saskatchewan. Thank you. You are making a huge difference. But before we hear from our 3 finalists, please welcome Arla Gustafsson, CEO of the Royal University Hospital Foundation. Sorry about that, Arla. Come on up.
While Arla's coming up, I'll just mention that our finalists have been blinded to their videos. So while they did provide some of the content, that they will be sharing it with us for the first time as well, too.
Thank you very much, Mary and Rachel. I'm sitting way back there, and I'm doing it for a reason, because this theater is here because of the community. Broadway Theater was something that was very dear to my heart in 1992. When it closed its doors, I was part of the board that raised the money to keep the doors open, and it's now 20 years later, and I have 5 seats back there. So I bought those seats, and I sit in them every time I can. So. Tonight is a very exciting night for Women Leading Philanthropy, and it is because of you, our WLP donors, that we are able to award our 4th $100,000 grant to one of our 3 finalists. Thank you for your dedication as donors for women's healthcare and for women's research. Your support and your participation as donors is humbling. This year, Royal University Hospital, or last year, turned 65 years old. I turned 65 this year, so I should be able to keep that right. And we are celebrating 38 years as a foundation supporting healthcare innovation at RUH. Thanks to donors like you, we have been able to raise and invest $155 million into transformational patient care, innovative research, and continuing education. In January of this year, we launched our new Mission Possible Operation New OR campaign, focusing on the future of surgery and transforming operating suites, technology, and innovation, as well as the surgical experience at RUH. That is our vision. This is such an exciting campaign and so relevant. As we all know currently, the postponing of non-essential services at our hospitals as we enter into or are going through the 4th wave of COVID-19. And we know that the recovery from this pandemic will be felt for years to come. It's a great time to get our surgical suites into the century. They're 43 years old, and it's time to make them the best possible space for our surgeons. I would be remiss not to take this opportunity to thank our healthcare professionals, many of you who are joining us here this evening, for your service, for your hard work, for your sacrifice over the last 18 months. We stand behind you, beside you, and are grateful for your leadership and hard work, so thank you. I also think that it's important to acknowledge the hard work and the dedication of our WLP Volunteer Steering Committee, who continue to work behind the scenes to drive the success of this program. Lisa Collard, Angie Hicks, Sonia Lee, Nicole Payne, Diana Pereira, Michelle Primo, Kaylin Schrader, and of course, Mary Kinlock, and our honorary chair, Rachel Melky. And behind our volunteers is our incredible staff team. During COVID, we pivot every day. Lisa Sands, Tricia Hogan, our incredible Michelle Morrison, and Lisa Weigerblad, and the rest of our staff who every day make this happen. Together with over 130 members, donors to WLP, we are transforming healthcare and creating a history of inspiring women. Thank you. I'd like to, at this time, thank Affinity Credit Union, who stepped forward with $250 each for every new donor to WLP from June 7th to this evening. And we have over 20 new WLP donors. Our program would not be possible without the support of our great sponsors. MNP, Leland Kempinski, D&M Images, Encore, Handy Special Events, Hilberg and Burke, Humanly, Branding and Marketing, and 1330 Creative Studio. And last, but not certainly least, I'd like to acknowledge Sky Planning Group. Tracy Duff has been so generous since the inception of this program, and we are so grateful for her continued support of the WLP program. Tracy isn't able to be with us here this evening, but I'd like to thank you at home, Tracy, for your support and your continued passion for healthcare. And I'm going to invite Rachel back.
Thank you, Arla. Ladies, please welcome our first presenter this evening, Dr. Brittany Ellis, and her project, Geriatric Emergency Department Intervention Nurse, a pilot project to better support older people in the emergency department. Dr. Ellis is the provincial lead for Geriatric Emergency Medicine, GEM, and works clinically as an emergency medicine physician. She holds a Master's of Science in Public Health at the University of Edinburgh and worked in dementia policy and service development. She is the current chair of the National Geriatric Emergency Medicine Committee and is dedicated to enhancing emergency department care of older people. Please welcome Brittany.
Medically, socially, and physiologically complex, older people often require increased time for care and support, be it in the community or in the ER. These commitments and demands are often challenging for carers who balance looking after their loved ones with other life responsibilities. And while being a carer is extremely rewarding, it is also extremely challenging, under-recognized, and undervalued. I'm Brittany Ellis. I'm an emergency physician in Saskatoon and the provincial lead for geriatric emergency medicine. I'm also a daughter, a granddaughter, and even a great-granddaughter, and I'm leading a project this year for Women Leading Philanthropy to develop and implement a new and exciting role in the emergency department, a nurse specifically there to look after and improve the care of older people. There's something unique about working in the emergency room. The interactions I have are single. They're short-lived. I often have to establish rapport rapidly, to assess, investigate, and manage expeditiously. This does not allow me to have the ongoing relationship with my patients that many others do. In fact, the joke I often have is that while it's really nice to see them, I hope I never see them again. And universally, my patients agree, because no older person wants to depend on the care that I provide in the emergency room. Because of these isolated interactions, it was challenging to find someone to share their experience directly with you. But with the help of my co-applicants and collaborators, I was able to meet and to live through the experiences of up to 5 carers who were sons, daughters, husbands, and wives of older people, who were willing to share their stories and willing to share with us their experiences. One carer, Anne, reflected on experiences with both her mother and her father in the ER. She spoke of many challenges, including those around poor communication with her cognitively impaired mother and communication with community services when her mother was discharged without appropriate supports in place. Her mother had developed delirium, a state of acute confusion we sometimes refer to as a brain emergency. Yet this emergency is one that is missed in up to 70% of older people in our ERs, including Anne's mom. Something this program has the ability to improve. Another carer I met with, Bev, shared with me the experience she had with her mother, who was in her mid-90s. Her mother had dementia, which was not formally diagnosed when she suddenly began to decline at home. Bev's mother, who maintained good physical health, was inviting strangers into their home, wandering at night, not taking her medications, and acting very differently. This caused Bev, who was also looking after her own family, to be overwhelmed and to feel unable to provide safe care at home. It led to an emergency room visit, as they felt they had nowhere else to turn. The visit led to a series of back and forths, where Bev sadly felt her concerns were under-recognized, where her mother's changes were not fully appreciated, and where communication amongst providers was poor. At one tearful point, Bev turned to me and said, "But I do know if there would have been someone there with more geriatric experience, things could have ended differently." And the hardest part is Bev was right. There are things we can and should be doing better, and I hope through your support and through the implementation of this program, we can greatly enhance care of older people in our ERs. The pilot project will be thoroughly evaluated so we can position it as what it truly is, an essential service, and so we can grow it across the province. The aim of our program is simple: to improve care of older people, largely older women, in the emergency room. This will be achieved through the development and implementation of a nurse specifically trained in geriatric skills to look after and guide the care of older people in the ER. The nurse will have dedicated time, resources, and skill sets to help improve outcomes and experiences of older people. The nurse will have the opportunity to help older people with issues that other ER providers do not traditionally have capacity for. For example, the geriatric nurse will ensure medications are thoroughly reviewed. They'll educate on and screen for important conditions such as delirium, dementia, abuse, social isolation, and loneliness. They'll ensure that good communication practices are employed, that carers and patients understand what happened in the ER, what their future steps are, and that they all have access to meaningful resources once they leave. All of the projects here today are important, and all deserve your support to be implemented. But by supporting our geriatric emergency room nurse, you will have the opportunity to stand up for older people, for older women in Saskatchewan who deserve better care and better services in our emergency rooms.
Thank you. Wow, that was the first time I did get to see that. It's always interesting watching yourself for 5 minutes, but I hope you enjoyed it more than I did. Thank you all so much for being here. As I said in the video, I'm really honored to be here, to be speaking on behalf of a fantastic group of women about our project, which is surrounding improving the care of older people in the ER. Before I get started, I'd like to do a little brief activity, and I'm going to need your rapid participation because otherwise Trisha's going to be shaking her fist at me in 5 minutes. So I just want to do an exercise, and I want everybody in this room and virtually at home online to stand. I want you to stand if you're involved in caring for anybody 65 years or older. Now, whether that's phoning them to check in, picking up medications, dropping off groceries, it might be personal care, it might be more support than that. Please stand. Okay, and now I would like Arla Gustafsson and everybody else who's 65 years or older themselves to please stand. Thank you. And lastly, if your parents, your grandparents, your in-laws, or somebody else that's near and dear to your heart is over the age of 65, or 65 indeed. Now, what might surprise you is that 25% of you standing today will be directly impacted by the care needed in the emergency room for somebody 65 years or older. 1/4 of older people will require emergency care within 1 year from today. And that's just to demonstrate the impact of this project. Thank you for your participation. We can be seated. So older adults use the ER more than any other age group, and that may come as a surprise. Unfortunately, it may come as a surprise as well that emergency rooms were never built for older people. Emergency rooms were built on models during wartime, on acute trauma care, on infectious disease, surgical medical emergencies like strokes, bowel obstructions, heart attacks. And we're pretty damn good at these things. But these things, which I sometimes refer to, and right or wrong, is the sexy part of medicine, do receive a lot more attention and a lot more glory in the ER. But older people, they don't. Older people, for the first time in Canada a couple years ago, outrepresented children. There are now more older people in Canada over the age of 65 than there are children. Yet in Saskatchewan and across the country, they continue to be poorly recognized in healthcare. Older people are routinely left out of research. They're routinely left out of important trials because they're excluded based purely on their age. Older people receive substandard care, and until recently highlighted by the pandemic, they seem to be somewhat of a forgotten group. In the video, you heard about a couple older people and their reasons why they use the ER. And while many older people do use the ER for trauma, for infectious disease, they also come in because of memory concerns, because of medication side effects, because they're on 10 of them, because they have multiple diseases, and because they just can no longer function at home independently despite the fact that they really want to. They use the ER because they have nowhere else to turn. And unfortunately, this means that sometimes they have bad outcomes in the ER. Older people have more falls, they miss more essential medications, they develop delirium or that acute memory issue that I talked about in the video. They even have increased risk of illness and death upon leaving the ER. And women, as women, we're affected by these factors that lead to ER use so much more than men. We're very fortunate that we also live longer than men, but this comes with challenges too. As women, we're more likely to live our later years alone. We're more likely to live these years with a lower income. And we're also more likely to live our last years in care. As women, we have more disability, more medications, and more disease as we grow older. And as women, we're more likely to be victims of abuse and neglect. So, as women, we stand very much to benefit more from the changes I'm talking about here today on improving ER care. And it's not all bad news, because the model I'm talking about today, our geriatric nurse in the ER, has been shown in other places to support significant improvements. Having geriatric nurses leads to decreased subsequent decline upon leaving the ER, decreased return visits to the ER, decreased admission rates in some trials, as well as it saves the healthcare system money. But most importantly, it improves patient and caregiver experiences. So as you heard in the video, the project aims are simple. It's really to develop a role specifically to look after older people in the ER, to give a nurse dedicated skills, dedicated time, to provide more comprehensive care, where they can screen for important geriatric conditions such as abuse, neglect, delirium, falls, medication side effects, and they can take the time to truly explain these. They'll have increased knowledge of the resources available to them in the community and how they can effectively get their patients and their carers there. They'll have the opportunity to act as an advocate, to provide caregiver assessment and support, and to champion geriatric initiatives. Now, the plan ahead for me is ambitious. Even with a little one on the way, though, I think it's achievable. The winter and spring of this year, we plan to further develop our training program, to look at the job description in more detail, and to focus on determining our outcomes and evaluation metrics more thoroughly. After that, moving into the summer of 2022 and 2023, we'll plan to do the implementation for up to 1 entire year of a full-time geriatric nurse in our ER, as well as a subsequent alongside evaluation. And the positive impact of this project is well documented, and I've been one to shout about it to whoever will let me bend their ear up to this point. But unfortunately, I haven't had the opportunity to bend it far enough to receive any funding. I've spoken now to ministers within the government, to SHA executive directors and directors, to the Health Quality Council researchers, Health Quality Council of Saskatchewan, and so far I've not been successful. So I'm up here to ask for your support in demonstrating the utility of this service, as well as the fact of what it really is, which is essential. COVID has been really hard, but COVID has forced us to talk about something that I refuse to let the conversation die on, and that is how we, the royal we, value seniors in our society. The pandemic highlighted a crisis of inadequate care, of inadequate funding, a crisis of not listening to what seniors truly want, and a crisis of abuse, neglect, and suffering. And I'd like to take the opportunity to keep this conversation going, to keep the recognition of the importance of seniors and the benefit that we can have by coming together, by uniting, and by supporting projects such as this one to improve the care of older people in our ERs. So I'm hoping through your vote and generosity, you can help me take a step forward and develop the first geriatric emergency nurse in Saskatchewan here at RUH. Thank you.
Thank you so much. That's wonderful. I wanted to take a couple minutes here just to ask you a couple questions to the audience. Why don't you lead off by telling us how in 1 to 3 years that you would see or envision the care would be different for women in our community and at the Royal University Hospital because of this funding?
Sure. I think it's important that one of the things I really see this project is a bit of a stepping stone. Okay. I see this project as an opportunity to demonstrate the effectiveness and then to grow it from there. So I don't just see this project, although the funding would go specifically to RUH, I see this as the opportunity to say, like, this is important, and we're now going to grow this across the province. And unfortunately, in a lot of things that we do, you require a little bit of proof and a bit of evidence to get things going. And that's what I need support in right now. When I think about how if I were an older person, I walk through the door, how things might be different, because I think that's a useful kind of thing to imagine. I think you get to triage and you get a little bit more time, a little bit better communication opportunity to share your problems. I think you have nurses assess and screen for things that we often miss, unfortunately, like abuse, like delirium. And these things are things that we can actually intervene on. We can make differences in. But most importantly, I think the biggest thing that's going to change is older people and older women will leave the emergency department feeling like they were heard and like they're being supported.
Wonderful. Can you briefly just end with why should women leading philanthropy donors vote for your project?
That's tough because they're all really good, but I'm here for this one. I think really it kind of goes back to what I said, is that, this is really an opportunity for us to take the momentum that we've developed over the last couple of years, which has been largely negative from the pandemic, but also take that momentum and say, look, older people have been affected worse, but it's not just the pandemic, right? This has been going on for years, and the ER, we're now just recognizing this as well, and now we can take that momentum of the poor, of the problems, and say, now we can do something about it. Because, in the old things, you can't fix a problem until you actually accept that there is a problem. And I think by highlighting this problem and supporting this project, we can demonstrate that there is a problem and that this is something we can do something about.
Wonderful. Thank you. Thank you so much
for
your
Thank you.
I'm pleased to welcome our second finalist of the evening, Dr. Janine Eckstein, and her project titled Pregnancy and Cardiovascular Risk Reduction Clinic. Dr. Eckstein is an assistant professor at the University of Saskatchewan and works as an interventional cardiologist in Saskatoon. Following training at the University of Saskatchewan, she completed a clinical fellowship at St. Michael's Hospital in interventional and structural cardiology. She returned in July of 2019 to Saskatoon to join the cardiology division. Best of luck, Dr. Eckstein.
We know that women are just undertreated. They are underdiagnosed. The tests aren't as accurate, and they often don't get the same treatment and attention in hospital. We know that cardiac disease actually has some of the most research on sex differences than any other specialty, and yet we still haven't applied it in clinical practice. Hi everyone, my name is Dr. Janine Eckstein. I'm an interventional cardiologist and I work in Saskatoon. I work in the cardiac cath lab, which is where we fix arteries for people that are having heart attacks or having a lot of chest discomfort. And we do that by putting a stent in, which is like a tube that we inflate within the artery. And that is something that I've been doing for 2 years now. And it is an absolutely life-saving treatment, and it makes a big difference in women's lives and also men's lives that are having heart attacks. And that's my main specialty. But one of the things that I've really been interested in is women's heart health. And we know that in Canada, and we've known for over 20 years now, that heart disease is a leading cause of premature death in women in Canada. What that means is about every 20 minutes, a woman in Canada is dying from heart disease. And it's actually not surprising. We also know that about 3/4 of the time, early heart attack signs are missed in women. And that's leading to women that present with their heart attack having higher mortality rates than men, and also being much more likely to have a second heart attack. And so this is a problem that definitely needs to be addressed, and is something that I'm really passionate about, and is why I wanted to look at setting up a primary prevention cardiac clinic, particularly geared at women in pregnancy. The reason for that is because we know that most of the risk in women is also reversible. We know that people with high blood pressure, people with diabetes, people with cholesterol problems, smoking, inactivity, all of those are things that we can work on in the right setting, and that actually contributes about 96% of the risk in women. And it means so much more to a woman than a man, because they have higher risk for any risk factor, but if we treat them, they actually have more benefit. And all of this seems so simple, but it's been things that we've known for decades, and we just haven't been able to really make it into clinical practice, and we've never focused on women and cardiac disease. From a primary prevention point of view, we know that women are often not paying attention to their health when they're younger. And this is natural. We're all young, we think that we're indestructible, we don't want to think about heart disease till we're older. But young women go through pregnancy, and pregnancy is a 9-month stress test for the body. It is the biggest stress test that anyone will ever go through. And we know that some things start to show up during pregnancy. Women can develop high blood pressure related to their pregnancy, problems with diabetes in pregnancy, as well as preeclampsia and eclampsia that are problems with the placenta. And all of these are risk factors for early heart disease. We know that these patients are actually coming to healthcare, and otherwise they are women that may not be paying any attention to their health. They may be from northern or Aboriginal communities, or they may just feel healthy, but they're finally seeing someone in healthcare, and that's when we have a chance to make a real difference and change their outcome. So what the goal of my project is to take women that have cardiac risk factors during their pregnancy, or women that we already know have heart disease but are pregnant, and bring them into a clinic that has a multidisciplinary approach. I want to have them meet with a dietitian and an exercise therapist, as well as have nursing support and physician support to teach them what this really means and how we can change their lives going forward, so that they don't end up with a heart attack, so they don't end up a statistic like we currently have in Canada right now. Through this clinic, they will get multidisciplinary care, and the goal is to empower them, to teach them, and to also help them make positive changes, including about their diet and about exercise, and follow them up, not just in person, but also have the option to follow them up remotely over time, and really look at whether we can make changes in their cholesterol levels, in their diabetes, in their exercise levels, and ultimately long-term change their lives. Preventative medicine wasn't something I was taught a lot in my residencies for internal medicine or for cardiology, and that's because often in centers we get so busy just treating what we have in front of us. We treat what we already know is established, and we're focused on trying to fix people that are coming to us in hospital, and there's so much of a burden because a lot of people are without a family physician and a primary healthcare provider. Again, and that's even more prevalent in the northern and Aboriginal communities. There is a much bigger role for preventative medicine, and it just needs to be something that we take the time to do. And it's much more about education, and it's trading the procedure, the cath lab, things like that, that I love and are an integral part of my job. But it's trading that for sitting down and having a sit down one-on-one with someone and really talking to them about how they can change their risk. We can improve our work as physicians and our care in a multidisciplinary sense, while also empowering women to help themselves and hopefully have that spread through the community so that they can take it to their friends, to their family members, and make a difference and get other people interested in really talking about their cardiac health, because that's how we ultimately make the difference. Thank you everyone for being here tonight, both in person and virtually, and really supporting this event and the years past. It's very exciting to be here, and I really appreciate the opportunity. My name is Dr. Janine Eckstein. As the video said, I am an interventional cardiologist at Royal University Hospital. And what that really means is I am a fancy plumber. I deal with clogs in the pipes. Those pipes happen to be attached to your heart and happen to be very important to your heart health, but I fix clogs, and that is what I do. And I'm quite honest about that being, there's nothing fancy about it. The truth is, my project isn't about what I do day to day. I fixed arteries, I put stents in, I fix heart attacks. This is about primary prevention. So my title is Pregnancy and Cardiovascular Risk Factor Reduction Clinic. Pregnancy is a gigantic stress test, which women have known for a long time, but the medical community is just catching up to. And we know that women can develop high blood pressure and diabetes during their pregnancies. And we know that that does mean they're at higher risk in the future. We're seeing that heart disease, we know it starts early. We know it starts in your teens, in your 20s. We've known that for decades. Now we're seeing that in pregnancy, we can see these risk factors as well already starting. And we can treat those. And some of them are women that already have these risk factors before they're pregnant. Some of them have seen their family members go through heart disease and are worried about the medications they're on and how that could affect their pregnancy, but coming off of them, worried about their own cardiac health and what could happen to them. And other times, it's just people's first real time getting to see doctors. A lot of these women are young, and even if they aren't, a lot of people are busy with their families. We give a lot to take care of our children, to take care of our spouses, our partners, our families, our elders, and we don't take time for ourselves. And that's where we're really losing, because a lot of risk factors for heart disease, they're reversible, they're treatable. We just need to know about them and we need to pay attention. So for me, it's really important that we look at primary prevention because it's not as flashy. It's not the thing that everybody talks about. It is always about what we can do to treat the big heart attack. It is always what we can do to help somebody coming in with a stroke, with someone with a trauma. And that's incredibly important. But at some point, we have to start changing the game. We can't keep doing what we've been doing. It's not working. We all know someone in this crowd, I'm sure, a dad, a mom, a mother, our sisters, our children who have had heart disease. We know that this is a big deal, and we know that it's not getting better. The clinic would take women who have had risk factors identified in their pregnancy or who have them before and enroll them in a multidisciplinary clinic where they get the chance to meet with a dietitian, with an exercise therapist, and with nursing care as well as physician care, and actually really talk about what follow-up testing is important, what they can do, what this means for their future, for the future of their family's health as well. And the big thing here is we can make a change. These are people that are young. We can change the course here. We're not too far gone. We can make a difference. And each of these women, through actually coming through the clinic, can have a difference on their own family's health by being healthier for their family, can have an impact on their friends by sharing what they learn and what they know, by having an impact on their communities at large, because we need to stand up for ourselves. The education is lagging way behind the research. And so we do need to speak for ourselves as women, and even for the men that we know in our families and in our communities, because this is real. And we do have that change. A lot of primary prevention is left up to family doctors, and we know that our family doctors are so overworked. A lot of people don't have family doctors, they can't get in to see them. Education doesn't take a 7-minute clinic visit. It takes time, it takes follow-up, and family doctors are overworked and don't have the ability to do that. And we can't ask them to do more. Everyone is doing everything they can in this province and in Canada right now, and it is hard to ask them to keep doing what they're doing and then do even more, because we're all busy. But data shows that less than 20% of women that have these early risk factors in pregnancy that we know about, less than 20% of them are showing up within 6 months for follow-up and for getting care. If there's at least some form of a women's clinic available, that number goes up to about 45%, which is still less than half of women are getting what they need to make sure that they're getting better, that they're getting healthier, and that they're moving forward for themselves. My goal is really to change from what I do, and I love what I do. I love treating people, treating men, treating women, treating anyone who has heart disease. And I like being an interventional cardiologist and fixing arteries. But my goal is to switch from treating women who already have heart disease to showing them how to prevent it, to educating them and helping them in their communities. And that starts young. And that impact grows year after year, the earlier we start. Because every person I see on my table, every person whose arteries I fix, is someone's father or mother, their brother, their sister, and sometimes their children. And I know that every time I have someone on my table. And I know that a lot of them could have prevented getting onto my table if they had just had those right opportunities. So that's why this project is important to me. The timeline would start in January, February, where we start with hiring a dietitian, an exercise therapist, and nursing, and as well as creating educational materials for the clinic and an online portal that can help for some people that have more of a busy schedule but still want to be involved. And then planning to go through family doctors and obstetricians in Saskatoon and people coming through JPCH and really let them know that this is an option and what we can do for women. And then start enrolling and seeing the first patients in clinic in about April. The clinic would start at half day every 2 weeks and would go up depending on need, up to a half day per week. And some patients will need multiple visits and some people will only need 1 or 2. The goal is to have people go through it for about 6 to 12 months and see how they're doing, to follow their blood sugars, to follow their blood pressures, to follow whether or not they are able to stop smoking and if we can help them with that, to look at their exercise levels and really see how they're doing. And ultimately to create a registry that helps research going forward, because all of these women have the chance to change. Without funding, care will continue as it is, which sounds both fine and sounds horrible, because we're not doing enough right now. So care can continue the way it is, but that means that less than 50% of women are being seen. That means through a family doctor, less than 20% of women are being seen. That means that we continue with heart disease being the leading cause of death for women in Canada. And that's not good enough. And we can make a change. But primary prevention isn't flashy. There's not a lot of money for primary prevention. And that's the way things are because we're always focused on fixing what is right in front of us. So I guess the real question is, are we willing to start making a change? Are we willing to stand up for ourselves? Are we willing to stand up for our families? And are we willing to start looking forward at what we can do to make all of us in this room and all of our families healthier? And that's my goal.
I love that idea of meeting people where they are, that they're coming in because of a big life-changing event in pregnancy, and that they're going to then continue on hopefully better than what they came in. So if you could look forward, how will this transform the healthcare for women and their families?
So because the goal of the clinic is to follow people for about 6 to 12 months, within a few years we'll have had several groups of people that come through the clinic. And the goal is to have not just in person, but also the option for telephone, because COVID has really shown us that we can do a lot by virtual care. And to create a community through the online website that also allows women to communicate, because women support each other, and that's how a lot of current education has grown, is by women supporting each other, especially for some of the rare cardiac conditions. So going forward, we would increase education, and I would hope that the program would expand, not just from Royal University Hospital and patients being treated at JPCH, but also to across the province.
Great. And why should women leading philanthropy donors vote for your project tonight?
Again, as Brittany said before me, obviously all of the projects tonight are fantastic, and I think every project that has been funded by Women Leading Philanthropy is fantastic. Obviously, we're all here for a reason, and we all made finalists for a reason. But we are all women in this room. We all have families. We all know somebody that's had heart disease, men and women, and we need to work on ourselves. But also, if we can support each other, that's what's really important. And I think that's what this entire program is about, is women supporting women and going forward. And that's what I really want my project to be about.
That sounds awesome. Thank you so much, and congratulations, your work so far.
I'm pleased to welcome our third finalist of the evening, Dr. Jennifer Brown Broderick, and her project titled Human Papillomavirus Self-Sampling for Primary Cervical Cancer Screening in Underserved Saskatchewan Women. Dr. Brown Broderick graduated from the University of Alberta in 2009 and completed her residency and fellowship in gynecological oncology at the University of Ottawa. She practiced 4 years in Rochester, New York, before returning to Canada. She is now assistant professor of oncology at the University of Saskatchewan and directs several clinical trials as a primary investigator, including Saskatchewan's first ever gynecologic oncology. Best of luck, Dr. Brown Broderick.
When you live 3.5 hours away, you kind of have to think of where you're going to stay, what you're going to do with your kids, what kind of the treatment actually even looks like when you're doing chemo and radiation, because you kind of think of your hair is going to fall out and what does the radiation actually do.
My name is Dr. Jennifer Brown Broderick, and I'm a gynae-oncologist with the Royal University Hospital. A gynae-oncologist treats women with cancers of the uterus, cervix, vulva, and ovarian cancers. We're a bit of a unique specialty in that we have the chance of not only being women's primary surgeons for their cancers, but also treating them with chemotherapy when that becomes part of their treatment plan. I moved back to the prairies last year and have had the unfortunate opportunity of meeting many young women with advanced cervical cancer. Saskatchewan is a small province in terms of population, but unfortunately, the number of cervical cancers I've seen in just one short year after moving back has outnumbered the number I saw in living 4 years in New York.
I'm Melina Christensen, and I'm 33 years old. I'm from Priestville, Saskatchewan, which, if you don't know where that is, it's 3.5 hours from Saskatoon. About 3.5 months ago, I was diagnosed with stage 3 cervical cancer. It started probably about 1.5 years ago with just kind of random sort of discharge, went into some bleeding. I kind of pushed it off because we were building a house. Then COVID kind of happened and shut down all the hospitals or just kind of everything. And it was like, well, I don't really know if I want to go to those places right now. Then after Christmas, kind of got a little bit more aggressive, and I went to the doctor. They sort of thought it was just an infection. We kind of went on with that for a couple months. It kind of started to get worse, so I pushed the doctor to come see me, or let me come see them. And they rushed me into the gynecologist, which immediately they knew it was a cervical tumor.
We as women, especially young women, tend to put our own preventative health on the back burner with our careers, young, busy women who are prioritizing the health of their children and families. This, combined with the fact that in Saskatchewan, many of our families and women live remotely, where not only does it take time from their careers or families, it often takes travel, sometimes many hours by plane or by car to just get to a primary care provider. The result, sadly, is that in Saskatchewan, only about 44% of all eligible women are screened for cervical cancer. This rate drops to a dismal 18% when we think about the women in the north. This is part of the reason why we need to transform care.
Looking back, had I had access to an option for an earlier screening through a self-swab test, I feel as though this all could have been detected a lot earlier and such an invasive treatment plan could have been avoided.
My project for the Women Leading Philanthropy grant involves screening for cervical cancer using a self-administered vaginal HPV swab, or human papillomavirus swab. This can be collected in the comfort of women's homes and mailed back in a postage-paid envelope for testing. Human papillomavirus causes over 90% of all cervical cancers, and not only self-administered HPV swab is not only more convenient, but actually more accurate in detecting precancerous or risk for cancer cells. We have to eliminate cervical cancer in Saskatchewan. We have to save these women's lives before cancer is too advanced, ideally even before diagnosis. We need to let these women see their children's lives and let their children grow up with moms. This project can not only help provide screening to remote areas, but increase the dismal rate of screening of 19% in northern communities, hopefully to higher and even reach 100%. It can help inform the future of cervical cancer screening and eliminate it. Let's help reach women before their late cancer diagnosis, women like Melina, so that together we can stop seeing advanced cervical cancer. Thank you, everyone, for the honor of presenting tonight. Last year, for the first time, I was able to watch this on an iPad, so it's an honor to be here. Before I became a doctor, I was actually an engineer, and I worked in the oil fields. And when I decided to switch careers in medicine, I was what they considered to be a mature student, which is just a really nice way of saying I was old. But I went to medical school, and I had a 1-year-old on my hip and a master's degree and 2 years in the field. And by the time I hit residency, I was a mom of 2 with 2 kids under 5, a working husband who lived across the country. And what is the last thing we think of as working, busy moms, busy partners, busy wives? Our own healthcare. Our own healthcare. We put it on the back burner. We put ourselves last. So as you saw from the video, we have to change this. The dismal rates of cervical cancer screening in Saskatchewan, under 20%. 20% of all eligible women. We have to change that. But no wonder these women aren't getting screened. With most women living in rural areas where it takes 3.5 hours to even get to a family doctor, and in remote areas where even cell phone receptions I've witnessed to be quite challenging, these women are just surviving. They're just dealing with their daily lives, taking care of their kids, forgetting to take care of themselves. So how do we fix that? We transform cervical cancer screening and we bring it to them. We change how we do cervical cancer screening. We don't do it with a conventional Pap test. And we change it for women like Melina, or for another one of my patients that I've seen in this just short year I've been here. We'll call her Marie. She was 28 with 4 kids, aged 18 months to 10 years, and who, unlike Melina, unfortunately had even more advanced cancer. And not only had the experience of telling her about the diagnosis, but also having to tell her that she would unfortunately have to arrange for other childcare for her kids in the next few years, and they would grow up motherless. This from an entirely preventable disease, prevention through screening and through something HPV vaccination. Screening, however, has to be done differently. And how we can do that is, like I said, bringing it to them. Our goal is to reach 500 women, unscreened women, which when you look at the northern rates of less than 20% of all eligible women being screened, that's not hard to get to 500 women. Not only we will mail out these swabs, and these swabs are self-administered vaginal swabs, in postage-paid envelopes with clear instructions and education to mail back to us for testing. But also I have a team built with family physicians, gynecologists who not only work in the inner city of Saskatoon, but also in remote communities in the north up to L'Orange and further north. We've engaged a CIHR nurse, an Indigenous research chair in nursing to help us with culturally sensitive education in order to provide adequate education to the women of the north. Not only do we plan to mail out these swabs so that women have an easier time of getting cervical cancer screening, but also handing them out in some clinics in the inner city, such as the Health Bus, the West Winds Clinic, and remote clinics in the north, where some women still have a barrier, even though they're coming in for other healthcare, they just have a barrier to having a conventional Pap test. We can screen these women with a primary human papillomavirus or HPV test. We also hope to partner with a pharma company or a drug company to provide HPV vaccination to these women where coverage might not already exist. This project can not only transform care for cervical cancer screening for the women of RUH and in Saskatoon, but the entire province. It can also inform the government of Saskatchewan, because this is intended to be a pilot that then can inform the government of how cervical cancer can not only change to what we call primary HPV screening, or just using a swab, HPV swab, instead of a Pap test for cervical cancer screening, but can also inform the government on who should be screened with this self-swab. I know I would like to get a swab in the mail and do a Pap test that way, wouldn't you? It's much easier. But no other Canadian province currently has put together primary HPV screening, so nobody's doing this yet. Wouldn't it be nice if Saskatchewan was the lead? If this project does not receive funding tonight, because all the projects are fantastic, the unfortunate thing is that more women will die. That's the reality. They're already dying. You saw Melina's story. She's a young woman, and she's hopefully going to be cured with her chemo and radiation, but my other patient will not be. And this is unfortunate, something I have to tell people every day. The other thing is, unfortunately, our other funding opportunities, such as CIHR and large granting government agencies. The reality is, even though we live in a lovely country of Canada, a gender gap still exists. And that gender gap means that women funding for research projects such as this for women, by women, is unfortunately funded less than project for men. It's sad, but unfortunately statistically true. So this is why the funding through WLP is so important. So we can fund these kinds of projects to transform cervical cancer screening for women, save lives, and you have the power tonight to change the way we screen for cervical cancer. We have the power to change me not having to see women like Melina with stage 3 cervical cancer. Thank you.
Jen?
Hi.
So just a couple of questions. I would love for you to give just an understanding to the WLP donors about, say, in 1 to 3 years' time, how you would see it differ from what it is now. Like, what would you like to see? Mm-hmm.
So ideally, not only would the screening rates increase from the dismal rate of only 18% in the north to hopefully having screened all the women. That's very lofty. So over 3 years, hopefully 80 to 90% of women that are eligible, which, by the way, women aged 25 to 69. This is virtually all adult women.
Yeah.
You know, in the province, be screened. And the other thing, which is also a lofty goal, but this will actually inform how we change cervical cancer screening, is to inform the government on how we will be able to change cervical cancer screening to primary HPV screening.
Right.
And that's probably closer to a 5-year goal.
Right, okay. And then why should women leading philanthropy donors vote for your project?
And that's difficult because I went last, so you got to see all the great ones forward. But the reality is this project affects all women in Saskatchewan. And this province is so unique in that our population is, like I said, small, but very distributed. And these women are young and they have their whole lives ahead of them. They should not be dying in their 20s and 30s, and we can prevent this. Please help me prevent this.
Well, thank you, Jen. Thank you so much. I'm going to ask you to stay up here. And I'm going to invite the other two finalists to come up with me.
Thank you, Dr. Ellis, Dr. Eckstein, Dr. Broderick. Wow, this has been a really remarkable night, and I am so impressed with the caliber and the talent and the energy that we have witnessed. Before we move on with the program, can I ask each of our 3 project leads, thank you, you're already up here. We have a small presentation for you.
Brittany and Janine and Jen, I just want to thank all of you tonight. I want to thank you for your passion and your commitment to the healthcare of women in our province. And it is truly wonderful to see you here tonight pitching to our donors. Your projects are inspiring and they really amplify what we're trying to do here at Women Leading Philanthropy, which is allowing our donor group to support women-led projects so that we can launch you and your ideas to better transform the healthcare of women in our province. We have a little gift for you tonight, and I guess Rachel wants to say a few words about the gift.
So I've built my career on believing that when we empower each other as women, we truly can shine. So just wanted to present you all with something, as we know we're only going to be awarding 1 presentation tonight, to encourage the other 2 who don't walk away with $100,000 to keep pursuing what you know to be right in terms of changes to the healthcare system. It's incredibly inspiring to see you here doing this work on top of everything else you have on your plate. And I think on behalf of all of us, I just want to say a special thank you for all the work that you've put into this project, for the care that you're giving to women in the province, and for the work that I know you'll continue to do to advance care in our province. So thank you. Thank you. Thank you. Thank you, and you may take your seats, ladies.
Well, I know each of you are anxious to cast your votes after hearing those inspiring presentations, but before we do that, we want to make a draw for our door prize winner. Each of our members have been entered in to win a beautiful Hillberg and Burke piece, so thank you, Rachel. And I'm sure it'll be an amazing prize. So we'll draw for the winner.
Drum roll, please.
Oh yeah, you want to, sorry, Rachel, I always mess one thing up. You want to describe your beautiful piece. Hopefully it's this one that I just got. Is it this one?
I should probably know what it is, but I don't.
Okay.
I'm sure we have chosen something fabulous.
Oh, wonderful.
And the winner is Oksana, and I'm not going to attempt your last name. Congratulations.
So someone from the foundation, Oksana, will be in touch with you shortly. And now is the time that we've all been waiting for. And it's time to choose your 2021 Women Leading Philanthropy $100,000 grant recipient. So I'm going to ask you to get out your phones now, and you're going to scan your QR code. And you're going to have the option of number 1 for Dr. Brittany Ellis, number 2 for Dr. Janine Eckstein, and number 3 for Dr. Jennifer Broderick. Once your vote has been entered, you'll see a green check mark with the word sent, indicating that your vote has been counted. So if you're in the room and you need help, please raise your card up. And if you are online with us and you're needing assistance, then please write it into the chat. I'll give everybody a minute here. We're going to have our team at the back tally the votes and put them into an envelope, and we'll have them brought to the front.
I think we need a little bit of assistance right up front, please.
I want to check mine again.
I also just realized I left my phone in the taxi ride over here.
Good.
So
That's
if
great.
can I vote just by telling someone?
Well, I think that you should be able, I don't know what the,
Yeah. Hopefully I can track that down later.
for those of us that have come for the last 3 Women Leading Philanthropies, we've always done things just slightly different to keep this like an experiential experience for our donors. So the first year when we all could gather together and we were at Ramey, I think that we were so nervous that there was going to be such a long delay. I think it was like 30 minutes that we made everybody come out, and then we had those baton twirlers come in too from Brenda that presented it. It was awesome. But we are always looking for like different ways that we can provide some, not only just important education back to the donors, but also something fun, something that you look forward to coming to 3 times a year. You still have your presentation to go. Tricia, what do you think? Can we get started on Laura's presentation? Oh, I'm getting a hold on hand wave here. All right, we're ready to go.
Great. Well, thank you for casting your vote and for being here with us tonight. As we just experienced, WLP empowers women to determine how their donation dollars will be invested. This is your program, and this is a chance to use your voice and to make real change in healthcare for women and their families. Shortly, we will be announcing the $100,000 grant recipient. But before the grand finale, we want to provide you with an update from last year's grant recipient. We are excited to hear about how the support received from WLP donors is transforming healthcare and how the project and its team members have been able to persevere through the pandemic. Please welcome Women Leading Philanthropy Grant Recipient 2020, Dr. Laura Hopkins, representing the project entitled Enhanced Recovery for Gynecological Oncology, ERGO, Improving the Surgical Experience of Women with Cancers of the Reproductive Tract.
Well, hello again. I say again because, not because we met each other for the first time, mainly virtually, a year ago on this, the eve of this event, but because I felt like I had a little bit of each of you with me today. So here's a story for you. I was in the OR today, and today we launched Enhanced Recovery in Gynae Oncology. So this was a day that we've been anticipating and getting ready for a year now. And as you know from the updates that I've given over the past few months, we spent the first few months just getting the team together and making some plans and seeing how we were going to structure the project. And then at the first update, I think that was in January of 2021, we decided to divide the surgical experience into the 3 phases of intraoperative, pre-op, and post-op on either side. And we had a surgeon lead on each one of those phases, along with other members of the team, including internal medicine, hematology, anesthesiology. We had medical students, residents interested and engaged and very much involved. And the 6 months between January and June, the team worked. And we decided to assure standardization of all of the various changes, and there were 17 of them in total that we were going to implement. We wanted to assure that there wouldn't be any variation, and so we reduced variation by setting up pre-printed order sets for each of the phases of care. And those were ready more or less by the end of June. And the part that we didn't think about initially, at least I hadn't, I thought about it, but I wasn't sure the timing was going to be right. It turned out that we developed a companion booklet on major pelvic surgery for each of our patients to take them through explanations of what we were doing and why it was going to be beneficial to them and why it would help improve their outcome after surgery. And so we built that companion document, and it's very good. And over the summer, we were test driving our order sets and our patient information booklet in particular for ease of understandability on the part of the patient. We wanted to make sure that we didn't have too much medical lingo in there. Across the summer, as we went to the other members of the team, such as the preoperative area, the post-operative area, which is basically the ward, and the recovery room, and met nurses and nurse educators there. We got feedback, we received many suggestions, which we implemented. And so by the time today came along and we went live, so to speak, we really had the input of every person who either physically or virtually has contact with one of our patients from the time of referral all the way through to recovery and discharge home from hospital. So it is a fantastic thing that I can stand up here and tell you today that we have begun the transformation of surgical care at the RUH. And what we will now do over the next year is measure the impact of all these interventions and be able to quantify what kind of transformation we have made. And the reason why we'll be able to do that is because we collected all of our baseline data from our surgical outcomes from a couple of years ago. So I know what the starting point is. I know what our baseline data is, and we're hoping to be able to share even more of a good news story with you in the future. And I'll just give you an example from today of how I was delighted to see the impact, even on the first day of, and the other surgeons don't know this yet because I haven't had a chance to tell them about it. But so I was doing this case, and I wasn't going to mention COVID, but since you guys kind of started talking about it, I will say that the first patient actually got canceled today because she tested positive for COVID. So we had a bit of a scramble, and so we got the next patient ready. And she came down, and I explained to her that in particular for this part of her care, she was going to see us running through our surgical safety checklist, such as it was, which is fairly extensive. And I didn't want her to be alarmed if we seemed to be looking disorganized to her, because it was not that. It was just that we hadn't really been through it before with the team. And it was spectacular. It worked exactly the way I hoped it had. And there were a number of different other things embedded in the surgical safety checklist. So usually it's just, what's the procedure? Do we have the consent? Do we have a consent sign for blood transfusion if needed? What's the hemoglobin? Any other important lab values? How long is the case going to take? Do we need any special equipment? What kind of position do we want the patient in? Things like that. But now embedded in this surgical safety checklist are a lot of the preventative measures. And not just are we giving preoperative antibiotics, but what time are they going in? And in particular, when and should they be redosed? At what point after the surgery's gone on should we give another dose? Or if there's a certain amount of blood loss, and you can expect with a lot of bleeding that the antibiotics you've given may get diluted in the patient's body and so become less effective. So you need to redose in a circumstance like that. whether the patient screened positive for diabetes, are we following the blood sugars and keeping things controlled at the time of surgery. And so we went through all that, and it worked very well. I was pretty happy with it. So then we started the case, and it was the kind of case that we don't normally do in cancer surgery. So this patient had already had surgery a few years ago, and she had a relapse and had a giant pelvic mass that the bowel was draped over top of, and it was kind of the bowel stretched kind of fairly tight over the top of this tumor the size of a baby's head. And so we were working away at it, and I expected it to bleed, and she was bleeding, and I had some blood on hold, but not enough. And so we were busy mobilizing this tumor and managing the bleeding as it was coming, and at no time was it out of control. But she was bleeding a lot, and the anesthesiologist was busy calling for blood and doing all of his things. And then all of a sudden there was this little voice. Dr. Hopkins, would you like to redose the antibiotics now? Because the patient's lost 1.5 liters of blood. And I looked around, and there was this little nurse that I've never worked with before. I mean, I met her when I came in the room, but I've never seen her before. And nowadays, the way things are going on in the OR, you never know what nurse you're gonna have. There was some regularity to it before this wave, but now over the last several weeks, it's you're not sure who you're working with. All the more reason why a surgical safety checklist was so important, because it cleared the variation. There was no one in there that knew what I normally did or what I would like to do or what I needed to know. So there was this voice, and well, yes, we do. And yes, I would like the redosing of the antibiotics. Thank you very much. And anesthesia did that, and we've continued on and saved the day. Long story short, tumor's out, everything's fine. Everything's good. Nothing left. So very good. But I was reflecting on this afterwards, and I was thinking, there is the point of this. One patient at a time. Going forward, we are going to be able to enhance the recovery in gynae oncology day by day. And it's my hope as we go forward that this will not only impact our patients, but that there'll be some spread that can go across some of the other specialties. And an example of the reason why I hope that there's going to be spread is because we launched the project on Friday with a multidisciplinary grand rounds. So it was anesthesia plus OBGYN and surgery. And there were 84 doctors in attendance at that rounds. And I come from Ottawa, and I've never seen 84 doctors at grand rounds before, ever. Now it was virtual. But still, I've never seen that many physicians, and there was a lot of interest. We'd invited a colleague of mine from Ottawa in anesthesia who would, we implemented ERAS in some level of scope a few years ago when I was there. It wasn't like this with all of the elements, but we had many of the easy ones. And anyway, the anesthesiologist from Ottawa kind of smoothed things over for all of the other anesthesiologists who we expect to be working with in the OR over the next few weeks, because there are some very big changes with this project to how we give and manage medications for pain control. And there was, we had some uncertainty as to how much buy-in we were going to be able to get from our anesthesia colleagues. And after that rounds, I was feeling so optimistic and renewed even. Renewed hopefulness, especially in these times. And so I just want to say thank you for the support that you have given to us so far. I'm really hopeful for much better outcomes. And again, it's not about meeting the surgical standard of care here, it's about raising the surgical standard of care. And I can already feel it happening. So thank you very much.
Thanks, Laura. Thank you so much. We're so proud of you. All of us here. Laura, I'm proud of you. All of us are proud of you. Thank you for continuing your passion and the work that you do. This has really, I think, reinforced why we're all here and to be part of this great organization and group of people, women, that support other women. It really is a privilege to be part of such an amazing work and that we're giving a voice to make such an impact.
Yeah, it's incredibly powerful to hear the story. And just to reiterate, we are all super proud of the work that you're doing, especially through incredibly challenging times, and to hear the story about today, the first implementation. Wow, what great timing for us to all be privy to a successful launch. And even though we're not there with you in surgery, know that we are all fully behind the work that you're doing and the incredible impact it's going to have on patients. So thank you so much. Many of you will recall that last year's voting meeting during the RUH Foundation received a call from a donor who was so moved by Dr. Bearwell's project, the other project last year that didn't get funded, that she felt compelled to fund it. I was as touched by this as I know many of you were, and encouraged that if the unsuccessful project speaks to you and you would like to have a conversation about how you can support it, please call and help so we can talk to you about that, because that is a possibility as well. And especially hearing 3 amazing projects that all totally deserve to be funded, it's really, really hard to just choose one. So thank you again to Deb Vidal for making last year a reality, funding both projects. This was incredibly generous. Thank you.
Yeah.
Okay, now is the time we've all been waiting for. The votes cast online and in person have been tallied. Thank you to Dr. Brittany Ellis, Dr. Janine Eckstein, and Dr. Jennifer Brown Broderick for being here tonight and for sharing your vision for the future of women's healthcare with our amazing Women Leading Philanthropy donors. It has been an inspirational evening, and I'm so proud to be a part of this program.
And sincerely, good luck to all of you. And thank you for positively impacting healthcare on women every day for the work that you do. Your unwavering commitment to advancing women's health is inspirational.
Absolutely.
So are we going to do this together?
Yeah.
Okay. Okay, I'm going to come over there.
Please, come over.
I'm going to get my mask on.
All right.
Okay, you do it. I'm going to look at yours.
Okay. So, the winner as determined by the WLP donors the 2021 $100,000 Women Leading Philanthropy Grant goes to Dr. Broderick.
Congratulations, Jen.
Congratulations.
That's so exciting. Yeah,
We're not supposed to be close to each other, but I want to hug every one of you.
Congratulations.
Congratulations to all 3 of our finalists. You've truly given us an unforgettable evening and demonstrated the power of women leading philanthropy.
And to Dr. Broderick, we are so excited to support you and to watch the amazing change that will come thanks to your hard work and to the support that you're going to be receiving from all the WLP grant donors. We will see you in January for your first project update, and congratulations once again.
And you've now become one of the esteemed members of the funded applicants of Women Leading Philanthropy, and we hope to have you back here again to show what amazing transformations that you have brought forward.
So whether this is your first WLP meeting or you've been to every single one, I hope that tonight really articulates the power of women supporting women, and also the amazing things that we can do if we maybe just invite 1 or 2 more women to participate in this group. Every year we get more, but there's a lot more women out there who I'm sure would be super thrilled to hear about the incredible work that these powerhouse physicians are doing in our province that will directly impact each of us at some point. So I hope that everyone will take away the sort of call to action to tell at least 1 or 2 people about the WLP program, get them out over the next year, and let's try and fund even more of these projects in the years to come.
And so ladies, this brings the formal part of our program to a close tonight, and thank you so much for being here. As we leave here tonight, we would remember as women leading philanthropy donors that we are the ones who are sponsoring these female physicians to do transformational things as part of RUH and the patients and families that access that care. And your donation demonstrates your commitment to that women-led healthcare and initiatives at the Royal University Hospital. Women Leading Philanthropy enables your investment in a forward-thinking project like the ones we learned about this evening, and we know that all of these projects will have impact on the care that you or your family may one day receive.
I feel so proud to be a part of Women Leading Philanthropy. I encourage everyone to join us in building and growing our impact through the amazing work that happens because of WLP. Together, we have raised $500,000. Thank you again for coming tonight, and we look forward to seeing everyone in January. Stay safe and good night.
Congratulations.